Hello, ma'am.
Hi,
We'll
how are you?
begin with our webinar. We have had it, everyone.
Okay,
Yeah.
I can go ahead.
Hello, everyone. Welcome to today's event. Get your pink on. I'm Vinaksh, a third year MBBS student and a member of Sexual and Reproductive Health Task Force for Doctors for a Cause. Share my screen. Just a minute. So Doctors for a Cause is a non-profitable charitable NGO comprising of non-medicos, medical students, interns, and doctors, and is divided into 8 task forces, each working for a particular cause or serving a purpose to the society by providing those helping hands within their hearts. The two task forces primarily working towards creating breast cancer awareness are Sexual and Reproductive Health Task Force and Women's Health and Safety Task Force. Sexual and Reproductive Health Task Force works with the objective of no more hush, only hustle, and thereby provides a platform for sexual health related issues and solutions to these issues, ultimately erasing the stigma associated with these topics. Women's Health and Safety Task Force works with the objective of let's empower one another, allowing gender specific issues to be discussed in depth, along with health problems, crimes against women, and empowering women from all backgrounds in the society. Today's webinar will be broadly divided into two parts. We'll be having a presentation which will be followed by a question answer round where anyone can ask topic related doubts to our speaker. The questions are to be messaged to DFC Questions Alina privately through the chat box. I'd like you to note the point privately over here. We are also live on YouTube and people who have joined us there can ask their doubts in the comment section. We'll try our best to get all your questions answered. For any troubleshoots, contact DFC Troubleshoot Simran. Lastly, without any delay, I would like to welcome our speaker for today's webinar, Dr. Dhanya James, who is an occupational therapist currently working at Johns Hopkins Hospital, US. I'd like to hand over the proceedings to her. A very warm welcome, ma'am.
Hi, everybody. How are you doing? My name is Danya, and I'm just gonna fix my screen so that you guys can see my PowerPoint. Hold on. Are you able to see it?
Yes, ma'am.
Okay, great. Let me just put this on the beginning. Okay, great. Okay. So welcome everybody. I'm happy to be speaking with you guys today on breast cancer rehabilitation. From what I understand, breast cancer is more of a taboo subject in India. So I'd like to help break that stigma with you guys. So without further ado, let's get started. So a little about me. I went to college at Rutgers University in New Jersey. I am a doctor of occupational therapy in Philadelphia, and then soon after, I went to get my certified lymphedema therapist certification in Florida. And now currently I'm working on my master's in health informatics. And right after I graduated from occupational therapy school, I went into private practice specializing in breast cancer rehabilitation in New York. And then I went on to go to Johns Hopkins Hospital. So here, I'm still here, and I'm helping consult and work on expanding our Under Armour Breast Health Innovation Center. So I've been working on that, and I'm expanding into upper extremity rehab and clinical informatics. So very busy over here. So our objectives for today. We're going to understand physical and psychological side effects of various forms of breast cancer treatment. Understand guidelines for recommending exercise and activity before, during, and after treatment. And establish a continuum of care from initial diagnosis through rehabilitation. Now I'm just going to show you a visual of a typical continuum of care. I put an asterisk there because these can all change which step happens before each other. So a person will get their diagnosis, and then you can have chemotherapy before or after the surgery. And there's surgery, and then radiation, and then maintenance, reconstruction. These all can happen at different points, but generally this is what will happen Some people may not have radiation, some people may not have chemo or surgery. So it's very important to read the patient's chart and their EMR and make sure you have their history down, because this will dictate what you do in therapy. And you also want to consider the age, comorbidities such as diabetes, hypertension, respiratory issues. This can also play an effect on treatment. What their occupations were, if they were a mother, if they were working, if their occupations are going to be limited after they have these treatments, and what was their functional capacity pre-treatment. So yes, like I said, it's very important to thoroughly review the patient's chart for clear notes on progression of treatment. So with that, we're gonna go over some conditions. We're gonna understand some side effects. So as an occupational therapist, you're essentially giving the patient their normal life back. Stress after such an event is normal. And so the doctor gives the patient their life back, but after that, the patient needs to survive and they need to learn how to deal with what they just went through. You're talking about 6 months to a year of treatment. So having a patient go through that, we have to kind of scale them back and start talking about how they're going to cope with this for the interim. So some of the side effects of chemotherapy include pain, fatigue, weakness. Chemo-induced neuropathies is normally in the tips of patients' fingers or in their toes. Decreased endurance, cardiovascular changes, increased swelling, which can lead to lymphedema. We'll talk about that in a little bit. And cognitive changes, which is also known as chemo brain. So many of these changes, if not addressed, they can become permanent. Chemo-induced neuropathy can also persist onward. Some people will develop the symptoms and then over time, it can actually become permanent if you don't address it. With surgical treatment and radiation and such, it takes about a year before you see what permanent changes have happened. And when we talk about chemo brain, we talk about short-term memory deficits. It's almost like a patient has a fog over their brain and it causes inattention and forgetfulness and memory issues. So some side effects of surgical treatment. So now it's important to know the difference between mastectomy and lumpectomy. Mastectomy, you're removing the full breast, whereas lumpectomy, you're removing a part of the breast. Now mastectomy can be bilateral. So you can have both removed. And here's a picture, draw a diagram of a patient who had a mastectomy. So with this, you can see scar tissue, limited range of motion, postural imbalance, all sorts of things. As you can see with patient, she has, she's going to inevitably have a postural imbalance because if you have one scar, you have all this weight that's taken off from the other side. So think of it as almost a patient's like losing a limb. It's very personal, and the patient may not realize how hard it will be to remove the breast, but it ends up feeling like you're losing a limb. And, and you have to think about lymph node removal. So with these surgeries comes either a lymph node biopsy or axillary lymph node dissection. Now, depending on how many lymph nodes are removed from that axillary region, this can increase the patient's risk for lymphedema. It can also increase the patient's risk for more scar tissue. It can also increase the patient's risk for any type of post-surgical swelling. So common conditions following breast cancer. Please tell me if I'm going too fast, okay? I just want to get through so we can have questions. So cancer-related fatigue. This is a persistent sense of tiredness related to cancer or cancer treatment that interferes with usual functioning. So this is particularly tough because diagnoses are being caught earlier in women, and therefore fatigue impacts daily roles. So a mother or a caregiver or someone with a full-time job dealing with this cancer-related fatigue is going to be hard if you're going throughout your day trying to get things done. This is common and one of the most stressful side effects of cancer treatment. It's important to note that rest does not improve symptoms of fatigue. So if a patient is dealing with this type of fatigue, resting is not the answer. This actually makes it worse. So you really want to get the patient exercising at least gently to start and building up their endurance and stamina to get back to what they were doing prior to all this treatment. So here's a diagram of common symptoms of cancer-related fatigue. A lot I've already mentioned: physical fatigue, attention deficit, lack of concentration, nausea, short-term memory loss. So you've essentially followed this patient for almost a year, maybe more, of rigorous intense therapy. And this has infiltrated their bodies. So now the patient is declared cancer-free once they're finished, and then they can resume their normal life. But after going through something like this for almost a year, maybe more, it's very hard to resume a normal life. And this is one of the main culprits of why it's so hard to get back to what they were doing. So as a rehabilitation therapist, as an occupational therapist, a physiotherapist, it's our goal to get these patients back to what they were doing before all of this has happened. And now that buzzword, lymphedema. This is an abnormal accumulation of water and protein. It is a disease process, and it's a mechanical insufficiency of the lymphatic system. Now, I say that because when you think about other systems in the body, if you think of the nervous system, if someone has a stroke or a hemorrhage of some sort, the brain is able to rewire itself in different pathways. Whereas with lymphedema, when a patient has a lymph node dissection or a biopsy, that lymph node region is left damaged. There's no recovery. It's just the body just compensates for that region. So many times a patient is lucky and doesn't develop swelling, but more often than not, you will see patients with some sort of swelling, either if it's in their arm, their breast, or their chest wall. And this is harder to detect sometimes because it is a diagnosis by rule out, meaning you have to have every other test possible before they declare this lymphedema. And it is chronic. There's no cure for this. Therefore, patients must learn to manage with complete decongestive therapy, which I'll talk about a little later. This is something that I do heavily at Johns Hopkins. Lymphedema is like the gift that keeps on giving. It's almost like a daily reminder to a person that they have had breast cancer. So education prior to treatment is so important, and I'll get into that a little later as to why we should be pushing for rehabilitation for our patients. So axillary web syndrome. This is also known as cording. These are structures, they're like bands of scar tissue that inhibit shoulder and sometimes elbow wrist range of motion. You're seeing a picture here of a cord for a patient that's limiting their shoulder abduction. And you can see it's a visible cord. If you had your hand right there, you can actually feel the cord and like kind of manipulate it. I am able to manipulate it sometimes from the elbow if it's very severe cording, and sometimes even through the wrist and the finger. And when we break them, it's an audible snap. These can be exacerbated with radiation, and there's a controversial etiology in therapy techniques. There's a lot of therapists that say you shouldn't break them, and then there's a lot of therapists that do break them. I am of the school of thought where breaking the cord has never been detrimental to my patients. So until I see a lot of confirmed research saying that I shouldn't, I'm going to continue doing so. I go a little more aggressive than most patients. But generally, you want a patient to achieve full range of motion, and then we can discuss whether breaking the cord is actually necessary. I'm sorry, it's very early over here in America. So adhesive capsulitis, also known as frozen shoulder. So this, if you see in this picture, there is a red capsule kind of forming over the glenohumeral joint. That's your shoulder joint. Now, this is a bacterial capsule, so due to prolonged immobility of the shoulder, this can form around the glenohumeral joint. And this makes the patient significantly limited with their scapula and their shoulder range of motion. And this can lead to hypertonic musculature, postural imbalance, pain, and limited range of motion. And that's where your rotator cuff sits. You need external and internal rotation of the humeral head to increase your scaption to complete basic activities. Now think if you have frozen shoulder, these are some activities that will be difficult for you. Putting a shirt on, tying the back, brushing and washing your hair, putting a seatbelt on. These are things that will be difficult if you have a frozen shoulder. And radiation fibrosis. So this can cause skin tenderness, podorange discoloration, as you can see. Now, when you look here, the radiation field is almost like a square. It's a quadrant that is treated. A patient will have markers set, like little tattoos, to go through the breast. So that's where the radiation kind of comes through. So it can even come through to the back. And this can trigger more swelling and skin tightness and leaves the skin very thin and contracted. So again, can increase scar tissue. There could be hypersensitivity in the radiated region. And you can develop fibrosis as radiation duration increases. So this can also contribute to range of motion deficits. And you have to remember the symptoms of radiation fibrosis can manifest 3 to 4 weeks following completion of radiation. It's really important to educate the patient on stretching and moisturization during radiation, because if not, they can develop these symptoms and it could be really detrimental to their quality of living. Plastic surgery considerations. So a patient has done their treatment and now they're thinking about reconstructing their breast. There's 2 ways to do it. There's implant reconstruction or a skin flap reconstruction. There are pros and cons to both, as you can see here. So with the implant reconstruction, it's a quick recovery time. The patient has a mastectomy and then they have tissue expansion. So the patient has the doctor come in and expand the tissue expander in their breast so that they stretch the skin, so that by the time it's ready, they can just exchange for an implant. The one thing about implant reconstruction is you do have to replace it every 5 to 10 years. Your body may not be used to foreign bodies in it, and therefore you can develop a capsular contracture. I've also had patients where the implant has ruptured because of this. So you want to take a look at how the patient reacts with scar tissue. So you want to take a look at how the patient can deal with their prior surgeries. Whereas with the skin flap, you're grafting skin from other regions of the body to recreate the breast. So this has a more lifelike feel. You're using your own skin. The only problem is sometimes the graft will fail, and that can increase scar tissue, and it is a longer healing time. So a lot of people do not have 2 to 3 months to fully recover from the surgery. So you have to think about those barriers. A young working mother will not be able to do a skin flap reconstruction right away because they most likely do not have the time. But it is a one-time surgery, so if it's a success, it's personally to me, I feel like it's a safer way to go, even though the recovery time is a lot longer. So this is another look at breast reconstruction versus deep flap breast reconstruction. So as you can see with the deep flap, there's a graft taken from the stomach and put into the breast area. And then this follows a revision. There's usually maybe one revision just to nip and tuck different areas, but rehabilitation becomes very important here because you're focusing on decreasing scar tissue and increasing tissue mobility as much as you can. Many patients after the surgery can't even stand up straight. So you have to go in and really make sure this patient is comfortable, and they have to know their post-operative restrictions. Whereas with breast reconstruction, it's a simpler process and it's a quicker recovery time. It's almost a same-day procedure. But you also risk a ruptured implant, capsular contracture, your body not taking in the implant. So I wanted to put this, I'm a person, not just a diagnosis. You want to refer your patient to rehabilitation as soon as possible. Every patient will have a unique reaction to treatment, and that is normal. You want to make sure you look at the patient as a whole, physically and also mentally. You've been through a lot. So discussing treatment. You want to know the patient's limitations, and you want to tell them any restrictions from surgery or treatment, any active treatment concerns when the range of motion is no longer restricted, anything they should expect in terms of swelling, like lymphedema, scar tissue restrictions, medication side effects, other medical conditions. So this is important. We have to know these diagnoses, even though we're not the doctor technically, the medical doctor, we still have to know these things so that we can educate our patient on what to expect. And I wanted to put lymphedema precautions because this is a big one. The patient initially should avoid lifting beyond 5 to 10 pounds. This is a chronic risk, so you have to think about this for the rest of your life, unfortunately. You keep the skin closed to prevent infection. If the affected extremity is red, hot, and painful to touch, call a doctor or go to your nearest emergency room for antibiotics. Any cuts, bug bites, injections, open skin, apply antibiotic ointment and cover up with a Band-Aid. Whenever traveling via airplane, it is beneficial to wear a compression sleeve with the glove on the affected extremity. This is because the pressure change in the air in the cabin can affect how lymphatics move in your body. Therefore, you need constant compression to continue that rhythm. Now, when I see patients for the first time, this is the first thing I discuss with them. Patients who have radiation have a higher risk. Patients with full axillary lymph node dissection have an even greater risk. So you have to think about these things. Sometimes even chemo can do it, very rarely, but sometimes I do see patients who had chemotherapy and developed lymphedema. So definitely, first things first, educate the patient on lymphedema. So exercise recommendations. I would say 2.5 hours of moderate intensity exercise per week. That's also the equivalent of 1.25 hours of vigorous intensity exercise per week. That breaks down to about 30 minutes a day if you do moderate intensity. You'd be surprised, patients go in feeling really tired, and then once they get moving again, they actually start feeling like themselves. It's kind of just like getting back into the swing of things. So for doctors that are listening, for your MD consult, my best suggestion would be prescribe a consult with a certified lymphedema therapist or an occupational or physiotherapist who specializes specifically in breast cancer, because this is a lot of information that we have to give our patients. We should be telling them about lymphedema precautions and postoperative precautions. And we always communicate via notes, prescriptions, emails. I communicate a lot with the doctors on my floor. And this is a learning opportunity to work closely. We do similarly in other programs. I also do hand therapy, and we work very closely with the hand surgeons. And as a result, the outcomes are great. So I would like the same for breast cancer patients as well. So a treatment structure, patients typically come 10 to 14 days post-op. They may have drains and sterile strips in place at various points of their care. And typically a patient comes 2 to 3 times weekly for 8 to 10 weeks. We start with modalities. To keep it simple, we start with modalities, we continue manual techniques, transition to exercise programs. And we monitor swelling with circumferential measurements. And then following post-op precautions, we slowly progress the patient after they achieve full range of motion to progressive weightlifting. So it's very important to know when, how many weeks in we can start these type of activities. Now I'm just going to put a list of all the things that we do. These are just some modalities: cognitive rehab, weightlifting, CDT, scar tissue management. Another thing we do that I did not list is neural testing. Because there might be some postural imbalances, we have to check the nerves in the brachial plexus. We have to check for TOS, which is thoracic outlet syndrome symptoms. So this is another thing that we do, but a combination of all this. And again, we do this based off patient availability, scheduling, insurance, finances, what they present with. Again, it always goes back to what the patient, what their diagnosis was, and what they were treated with, how they were treated. So complex decongestive therapy, this is to fight lymphedema. It consists of skincare, manual lymphatic drainage, compression wrapping, and decongestive exercises. I'll go into this a little more, but these are some places you can check for certified lymphedema therapists. I did find there is one in India, the India Lymphedema Foundation, so you can try to connect with them, see if you'll find one. Manual lymphatic drainage. This is basically rerouting lymph flow from blocked areas into more centrally located healthy areas. This is a very relaxing massage, and this increases lymphangiomotoricity up to 60 contractions per minute, meaning the lymphatic vessels move quicker. So those collectors that move fluid, they move quicker with the massage, and then we wrap them. As you can see here, this is a patient who was wrapped. Usually I have a patient wear that until their next session. If they're coming 3 times a week, that's about, keep it on for 2 days. So it is a very time-consuming therapy. However, it is effective. When you think about an intact lymphatic system, MLD can counteract inflammatory response mechanisms for post-surgical swelling, abscess washouts, plastic surgeries. So it can be used in a lot of different ways. So this is a very big bulk of what I do for my patients for any type of therapy or any type of treatment they've had in the past. For cognitive treatment. This is, again, we're talking about that brain fog, that chemo brain that people talk about. You want to get the patient on structured routines or scheduling with medication management, especially. Technology, cognitive rehab through virtual reality game devices. We do that a lot here at Johns Hopkins. We have a lot of virtual reality game devices, which has worked very well in our clinics. But it can also just come down to simple pen and paper tasks to help the patient hold themselves more accountable for compensating for these deficits they may or may not have. Psychosocial considerations. The way you talk to the patient is probably just as important as the therapy itself, because many of these patients have anxiety of the unknown, body dysmorphia, information overload, poor sleep, and sexual dysfunction. Right here, there's just some sleep hygiene techniques for you to take a look at. But patients, think about they have treatment for 6 months to a year, maybe longer. And then after that, they have no more doctors following them. Their doctors, they had at least 3 to 4 appointments a week. Now it's nothing, and they just have to fend for themselves for another 3 or 6 months. That could be very scary for a patient, because when you have people constantly checking on you, and then you go from a lot of doctors checking on you to nobody checking on you, it could be intimidating. Patients will feel like they're disfigured after having some type of surgery or radiation. Talking to so many doctors, you're talking to your oncologist, your radiation oncologist, your surgeons, your plastic surgeons, now your therapist. This can lead to information overload. So facilitating ways for them to take in this information is also important. Because of these issues, patients end up having poor sleep. And because there's this body dysmorphia happening, there could be sexual dysfunction going on. A lot of younger patients are induced into menopause, and this can have a really big effect on how the patient deals with having kids in the future, and also how their sex lives will be. The considerations for the metastatic patient. The main goal with metastatic patients is comfort care. Your main goal is to focus on decreasing pain, preserving upper extremity function, positioning, proceeding with caution, taking vitals at each step to make sure the patient is stable, and wound care. We're thinking about skin mets, and we don't want to reroute fluid to lymph node regions with increased metastases. I had patients who I did MLD for, I did complete decongestive therapy for, and I was worried because he was a metastatic patient and the cancer was spreading and it was manifesting on his skin. But the therapy I did decreased the swelling for his hand, and it was really the only therapy, the only thing that he enjoyed late in his life. He did not like coming to doctor's appointments, but this was the one that he enjoyed because it enabled him to fulfill his daily activities and give him more quality of life before he passed away, unfortunately. He was a model airplane builder, and just this therapy for him 2 to 3 times a week, it really made a big difference on his quality of life. So you have to think again about the person as a whole. And this is just a quote. There's many studies out there showing the benefits of activity for breast cancer survivors. on average, there's about 33 to 40% reduction in breast cancer specific mortality with physical exercise. There's a couple other studies that identified that there's a 40% reduction in breast cancer specific mortality. And if you look it up, you'll see it. I have at least 3 or 4 studies listed in my PowerPoint pertaining to this. So again, that patient education is a key component of breast cancer rehabilitation. Building rapport, talking about energy conservation, managing their daily tasks, sexual health, empowering the patient with information regarding treatment. Again, your patient is getting a lot of information at once. So I find that written handouts and continually verbalizing these information is important. A home exercise program and teaching them sustainable practices for active living. And the nice thing about breast cancer rehab is you focus more on how far the patient has come, and you're not thinking too much about the past. You're thinking more about what we can do to make the future better, which is nice. So without, I think we just hit the 30-minute mark. So yeah, any questions? I'll just finish my slides and then we can go to the question and answer. You can connect with me if you'd like. Thank you for coming to my presentation. This is my email if you have any questions. Go follow me on social media. I have nothing really to hide, so these are my personal accounts. But yeah, please feel free to connect. I'd love talking about this and helping mentor people into doing breast cancer rehab, because I do think it's a very underserved population. These are my references, and yeah.
Hello everyone, I am Elena Ali, a member of Sexual Reproductive Health Task Force from Doctors for a Cause. I'm pretty sure everyone will agree with me that this webinar was really enlightening. Thank you very much, ma'am, for such a wonderful session.
Oh, no problem.
We have received a lot of questions.
Oh, sorry.
We have received a lot of questions from our participants, both here as well as on YouTube Live. We'll try our best to include all of your questions. The first question is from Sarga Mundra. Her question is, how common are fibroadenomas in early 20s and do they pose risk for cancer? On to you, ma'am.
From what I understand, fibroadenomas do not pose a risk for breast cancer. I've had a couple patients, it's not very common, unless it's just going undetected. I know patients who have denser breasts with more like cystic-like tissue can see a higher risk, but I don't know the exact numbers on that data. But yeah, I have seen it, and it typically it's a benign type of malignancy. So yes.
Thank you, ma'am. The next question is from Prajakta Umbare. Her question is, what are the steps that are essential for a country like India to implement cancer rehabilitation efficiently and cost effectively?
So what I find is that breast cancer rehab is pretty cost effective because you're mainly using your hands. It's a lot of manual therapy. I think the biggest thing is just educating doctors. We still fight that here in America, talking with doctors on referring patients. I even now, I'm helping open this breast cancer health center at Johns Hopkins, and it does become an issue. I think being able to have a champion for it, finding an occupational or physiotherapist that's very interested in this, and having them consult with doctors, having those meetings and talking to them about making referrals for their patients, and also emphasizing that this is more to improve their outcomes. So if you have a patient who has a mastectomy and they have a deep flap reconstruction, their outcomes are better if they go to therapy, if the patient goes to therapy. So emphasizing that this helps our patients, and this makes the doctor, their outcomes better. So you always want to take it from that perspective. But yeah, I think advocating and talking to doctors is the first step.
Thank you, ma'am. The next question is from Shivangi Ria. Her question is, in which condition does a tumor in breast becomes cancerous, and is a non-painful breast tumor a serious condition?
Yeah, I mean, if you feel a lump, you should absolutely go get it checked. Either or, a lot of patients don't feel any pain with their tumor if they have one. So I can't speak as to what the diagnosis would be exactly, but if you feel a lump in your breast, you absolutely should get it checked whether it's painful or not.
The next question is from Simran Patel. Her question is, how do cancer patients undergoing chemotherapy and immunosuppressants regain their immunity and daily life post-recovery?
It takes a long time. So a lot of these patients will remain immunocompromised. Again, the science is kind of more theoretical to me. It's more abstract. A medical doctor might have a better answer for that. But for the most part, these patients remain immunocompromised. So it is important to protect your health and educate these patients on that. I don't know if that answers the question, but hoping it did. So.
The next question is from Rupayan Das. Her question is, what is mantle cell lymphoma?
Can you say that one more time?
What is mantle cell lymphoma?
Mantle cell lymphoma, I would believe it's a form of lymphoma. I'm not particularly familiar with that diagnosis. I'm sorry. I will have to look into that for you.
The next question is from Rukmini Tanjore. Her question is, how do we encourage rural population to learn and get tested?
Yeah, that is hard because I think there's more of a cultural barrier here. It's really, I think the best thing, if it were me, I would probably have people go into the villages themselves in these rural areas and talk to these women, really probably away from men, so that they can have like a more of a safe space to talk about this type of stuff. That is a very challenging question, and it would be something I'd like to explore with you guys. Your first goal would be to break that cultural barrier. So just talking to these women and advocating for how important it is to get tested is the first thing. But you have to also understand that these rural populations need to help them understand why it's important. So the tact is very important, and how do you address this with patients?
The next question is a common question. It is, what are the basic steps that can be taken for early detection of breast cancer?
You take breast exams, self-breast exams. If you're, some people do it standing, like while they're in the shower. Other people do it while they're laying down. You just kind of lift your arm over your head and you kind of poke around and move your breasts in different directions to make sure you don't feel anything suspicious. Another thing that might be useful is just looking out for signs. I would do the breast exam first. That's probably the earliest way you can detect things, but also getting your mammogram every year. They say you shouldn't get it until you're about age 40, but I'm having patients that are younger and younger as years go on. I think my youngest patient was 24 and she detected it at 23. So, and most younger patients, if they're that young, don't detect it till much later. So looking out for those signs, if you see like the nipples are inverted or if there's discharge coming out from it, that's immediately needs attention. So I would say breast exams, self-breast exams from an early age, and probably think about doing your mammogram sooner than later.
The next question is from Ahan. His question is mastectomy the safest way to remove any cancerous growth without any further risk?
Not necessarily. If a patient has a lower stage of cancer, you have to think about the quality of life. More is not always better. Now, patients have had successful outcomes with just lumpectomy and radiation, as opposed to a full mastectomy with complete axillary lymph node dissection. I think a lot of it is based off the doctor and what they recommend. Some doctors are a little more aggressive than others, but there are a lot of studies saying that you do not need to do the full mastectomy, depending on the diagnosis, to get the same results.
The next question is a common question. It is that if someone's relative has breast cancer, how should they react and what should they do to help the patient?
Definitely giving them the support as much as they can. I would say don't make the person feel as if they're like an invalid. I know a lot of people will be like, oh, oh, I am so sorry for you. Let me do this for you. Let me help you with this. Let me help you with that. That is all great and all, but getting them medical attention is number one, and treating them like they're a human person as opposed to someone who's not able to do anything for themselves. The worst thing is having a patient tell me that they're like, oh, no one will let me lift a finger. No one will let me do what I want on a normal basis or let me do my job. Finding that fine line between being compassionate and helping is a very important thing. But I think definitely seeking medical attention or convincing them, I feel like that might be a bigger issue in India, convincing people to actually go get medical attention or just a test to see if there's something going on.
The last question is from Rachna Pal. It is, are tender fibroid lumps in breast cancerous?
Tender fibroid lump, they can be. So you want to get tested. I mean, just because you may feel something, if you feel anything abnormal, it's always a safer bet to get tested. Sometimes it's not. Sometimes it's just a benign tumor and just needs to be removed for whatever reason. That happens. But there is a chance that it could be something serious, and you want to address that as soon as you can. So even if it's nothing, at least you addressed it and now you have a better peace of mind because of it. So yes, I would say a tender fibroid. It's hard for me to say if it would actually be cancerous. That's something that even the most sophisticated doctor will not know without a test. So.
Thank you very much, ma'am, for clarifying everyone's doubt. We have a post-webinar feedback form. The link will be sent on the chat on Zoom. It's a request to everyone to please fill the form. Thank you.
Thank you, everybody.
Hello, sorry for the delay. Yeah, so good evening, everyone. I'm Tanisha Singh, and I'm a member of the Sexual and Reproductive Health Task Force. On behalf of Doctors for a Cause, I extend my profound thanks to Dr. Dhanya James for her stimulating and insightful talk on the topic of breast cancer rehabilitation. This enlightening talk has given us many insights into this complex yet very prevalent issue related to women health. Ma'am, we would again thank you for finding out the time out of your busy schedule. I would also like to thank the participants whose queries and observations made this webinar an enriching experience. I'm also thankful to our viewers who joined us on YouTube. Last but not the least, my thanks go out to my fellow colleagues who organized this webinar and gave us a golden opportunity to listen to this scholarly talk today. Thank you, everyone, and have a great evening.
And thank you for having me.